We will start the post-lunch session. So the first session is infections in acute pancreatitis. I will invite the chairpersons, Dr. Samir Moindra, Senior Professor, SGPJ Lucknow, Dr. Bharat C, Senior Consultant, Manipal Hospital, Bangalore, Dr. Basumani, Senior Consultant, Appal Hospital, Chennai.
Yeah, good afternoon. We are going to start the post-lunch session. We have 3 talks in this session, each of 15 minutes duration. And this is basically, all the 3 talks are infection related. So I would like to request our first speaker, Ms. Gauri Kumbhar, and he'll be speaking on when and how does infection sets in, tracing the origin in acute pancreatitis.
Good afternoon, everyone, and welcome to you for the post-lunch session. I'm Dr. Gauri, and I'm very much delighted to be back at CMC, my alma mater. And I thank IPC for giving me this opportunity. So I'll be talking on a very fundamental topic today, that is how and when does infection set in, tracing the origins in acute pancreatitis. So I'll start with a story of Mr. X. He's a 32-year-old male who was presented with 5 days of abdominal pain and breathlessness. He was diagnosed to have acute necrotizing pancreatitis, and on the 5th day of his illness, he develops fever. He has certain features of SIRS. He is tachycardic, tachypneic, and his labs on day 5 show total counts of 10,900 with neutrophils of 82%, lymphocytes of 8%. The inflammatory markers, his CRP is 54, procal is 1.2. The initial infection screen is negative. His CT is showing necrotizing pancreatitis with mild bilateral effusions, and his blood cultures are awaited. So the critical questions that we face here are, what are the causes of fever in the first week? Is it due to sterile inflammation or infection? And how to differentiate between these two entities? And what is the timeline of infections in acute pancreatitis? So to answer these questions, I would like to divide my talk under these 5 headings. That is, why infections matter in acute pancreatitis, how do they occur, what is the timeline, and we'll be talking infections into 2 parts, like infected pancreatic necrosis and extrapancreatic infections. So as we all know, most of the patients run a milder course, whereas about 5 to 10% develop severe necrotizing pancreatitis with organ failures. 60% of them have sterile necrosis with mortality rates less than 5%. But what is important is this other 40% where there is infected necrosis, and the mortality rates in these patients jump from less than 5 to 15 to 25%. And that's why it is essential to understand these infections for their timely management for better outcomes. So how does this infection set in? We all know the classic epidemiology triad. For an infection to develop, we need a susceptible host. In this case, we have patient with acute pancreatitis with immune dysfunction. You need an invading agent. Here we have gut translocated microbacteria, and you need permissive environment. So we have presence of necrosis. So in the coming to the first immune dysfunction, in the initial phase of acute pancreatitis, within 1 week, we have SIRS driven by TNF-alpha interleukin-1, and this is the fire. So this is the fire which drives the early organ failures and can cause early mortality. Over time, the immune response flips to the other side, that is compensatory anti-inflammatory response, which is the phase of immunosuppression, that is the freeze. And this is the time where infections set in and can result into late mortality. Now, what exactly happens in CARS is monocytes lose their HLA-DR expressions, the cytokine production shifts from pro-inflammatory to anti-inflammatory, the patient becomes lymphopenic, and more importantly, the activated Treg cells impair the duodenal barrier, causing gut translocations. The inflammation can also result to hypoxemic ischemic damage to the gut wall, causing bacterial translocations. There is thinning of mucus layer, there is Paneth cell dysfunction, and injury to the tight junctions, all of these contributing to the gut bacterial translocation. Coming to the third point, that is permissive environment. So we can see in this slide that as the extent of necrosis increases, the likelihood of infection increases. Now, how does extrapancreatic infections occur? So the translocated gut bacteria get into systemic circulation either via portal blood or by mesenteric lymph, or it could be acquired as a nitrogenic infection. So when do infections set in? Let's just put this on a clock. So this was a study done in CMC where we have looked at patients with acute pancreatitis presenting within 5 days of disease onset, and we looked at the fever profile of them. So out of 505 eligible patients, around 150 had developed fever. 1/3 of them had fever due to sterile inflammation, whereas 2/3, that is 102 patients, had infections. Half of them had culture positive infections, and more importantly, 36 of them had infections with multi-drug resistance organisms. Now, if you look at the fever profile of these 150 patients, 2/3 of them, that is 98, had fever in the first week itself, with sterile inflammation being the most common cause, shown here in blue color. Whereas if we look at second week and onwards, the most common cause shifts to infections, predominantly the infected pancreatic necrosis, shown in this dark green color. Now coming to the infection subgroup, half of them had infection due to infected pancreatic necrosis, and within extrapancreatic infections, LRTI, bacteremia, and cholangitis were the predominant contributors. Now this is one classic study which looks at the bacterial contamination rates of pancreatic necrosis. As we can see, they increase over time from 23% in the first week to almost around 98% by the end of third week. So this is another study which has looked at the timeline of infections. The extrapancreatic infections tend to occur around day 9, the infected pancreatic necrosis around day 14, and fungal infections set in late in the disease course around day 30. Coming to infected pancreatic necrosis, it occurs in around 20 to 30% of the patients with severe acute pancreatitis, monomicrobial in around 50 to 90%, polymicrobial in 13 to 64%. The main culprit organisms are the enteric GNBs, the E. coli, Klebsiella, Enterobacter, followed by gram-positive cocci, Enterococcus and staph, and fungal infections like Candida occur late in the disease course. Now this is the microbiological profile of the CMC study cohort, and as we can see here, Klebsiella pneumoniae is the most common pathogen overall, as well as in the blood and in the pancreatic fluid. And if you look at sputum, shown here in the green color, we can see that Acinetobacter baumannii emerges as the most common pathogen. Now coming to MDR infections, 20 to 40% of infected pancreatic necrosis is caused by multi-drug resistant organisms. The gram-negative ones are the ESBLs and CROs, and the gram-positive organisms like VREs and MRSAs. The risk factors being the prior broad-spectrum antibiotic use, prolonged hospital stay, multiple interventions, and nosocomial sources. And these MDR infections translate clinically into higher organ failures, mortality, and morbidity. So in the CMC cohort, we can see here that the mortality rates in MDR group are almost 4 times than the non-MDR group. So is there any impact of timeline on onset of infected pancreatic necrosis? So this study by Robert et al. Had looked at early versus late IPNs, and what they have found is early infections, that is less than 4 weeks, were associated with increased mortality with hazards ratio of 2.45, likely because this window overlaps with the immunoparesis phase, that is the CARS, and also the collections have not yet walled off. Now coming to the extrapancreatic infections, this is the first meta-analysis done by Brown et al. In 2014, which looks at 19 studies and 700 odd patients, where they have shown that the incidence of extrapancreatic infection is around 32%, that is 1/3 patients are getting extrapancreatic infections. More common is the LRTI, followed by bacteremia. So this is yet another Indian study where it shows that combined pancreatic and extrapancreatic sepsis leads to the worst organ failure rates and the lengthiest hospital stays when compared to either alone, and it was least in the sterile group. Now we saw that the EPIs are occurring early in the disease course. So can they predict infected pancreatic necrosis? So this study by Pando et al. Shows that extrapancreatic infections, especially the bacteremia, was noted to predict infected pancreatic necrosis with area under curve of 0.72. A brief about fungal infections. The reported incidence varies from 7 to 46%. The risk factors, again, being broad-spectrum antibiotics, interventions, prolonged hospital stay, mechanical ventilations, TPN. Candida albicans is the most common strain, and there is no role for prophylactic antifungals. Now, are there any predictors for infected pancreatic necrosis? So there are certain scoring systems like Apache, SIRS, PASS, MPASS, and its variations. And there are certain blood investigations, the routine ones like CBC, platelets, hematocrit, and the biomarkers like ProCal, CRP, neutrophil CD64, etc. However, the scoring systems are complex and the biomarkers may not be always available. So that brings us to NLR, that is neutrophil to lymphocyte ratio. It's a simple, inexpensive, and almost always available marker. So the CMC study also looked at NLR to differentiate between infections from sterile inflammations in the first week of acute pancreatitis. This is the ROC curve. The blue is NLR and orange one shows ProCal. And as we can see, NLR turns out to be a better predictor with area under curve of 0.7 when compared to ProCal with area under curve of 0.54. Now, if we look at the NLR cutoffs, at 6.2, we get a good balance between sensitivity of 77% and specificity of 58%. So coming back to our patient X, on day 5, we calculated his NLR. It turned out to be 10.25. We started the patient on injection meropenem. On day 7, his initial blood cultures had confirmed ESBL Klebsiella pneumoniae. He became afebrile within 3 days of therapy and completed 2 weeks of antibiotic course with good clinical recovery. Thank you.